Okay, we're going to start with infant cheat sheet. There is a lot of information on this one. Okay, this is where you're going to live. Okay, because this has testable stuff for this test, next test, third, all the tests. Okay, so very important to note. All right, you're going to need to know Erikson's, Piaget's, and Kohlberg's for each stage. Okay, but the most important thing is to understand how to facilitate that. Like, how do we lead the child into that stage? And how do we get them into the next one? And I'll talk more about that in a second. The first thing I want to talk about is a red flag vital signs. Now, you will see a million different references for vital signs for PD, okay? They're not going to ask you what is normal. They're going to ask you something that's out of normal, like when do you have to do something? Okay, so this is where we live for the whole thing. So I'm going to tell you today, and then from here on out, you should be like, okay? So typically normal respiratory rate is somewhere between like 30 and 60, just so you have a reference. Okay. But if the kid has a respiratory rate greater than 60 consistently when they're not crying, that's the important part, because when they're crying, right? Okay. So if they're just chilling in the crib, doing nothing, and they're over 60 consistently, that's a red flag. Now, do we pop oxygen on them? No, you need to assess and find out what's wrong. So remember, in nursing school, we don't do oxygen, right? Like, you hardly ever going to pick that on an exam unless they say like the kid is, maybe a little gray, or they say like, hey, they're not breathing or something. But even though you wouldn't pop oxygen on, you're going to bag them, right? So oxygen is usually not the answer, even though they try to teach you that in first semester. Okay. Usually babies have more apnea than anything, and you put oxygen on, they're not breathing. It's not going to be helpful. Yes. Okay. So the first thing you do is like stimulate the baby, like, hey, wake up, because babies forget to breathe all the time. Hence SIDS, right? So the first thing we do is like stimulate the baby. Oh my God, wake up. You forgot to breathe. And they're like, oh my bad, all the time. Okay. All right. So respiratory rate over 60 consistently without crying. Heart rate. So a typical average heart rate for an infant, and this is 0 to 12 months, just in case you didn't know what an infant was. Okay. Is going to be somewhere around 120 to 160. Okay, so if their heart rate is consistently over 160, because when they're crying, they'll be 180, 190, 200. Okay, but if they're over 160 consistently or less than 90, at less than 90, what's our issue? Perfusion, right? So if it's less than 90 consistently when they're just, everybody's chilling, okay, or greater than 160, then I would be concerned. Please remember that a fever is not considered a fever at all until over 100.4. Right? Okay. And this is very important in PD. Okay. Because if you have, let's say, a 6-week infant and they come into the ER and mom's like, oh, baby's been sick, whatever, we do a temperature and it's 100.1. We're like, okay, it's probably a virus. Take care. Right. If it's 100.4, which is only like 0.3 different, they're getting a full septic workup. CBC, chest x-ray, UA, urine culture, LP, all of that. So it's very important to get a very accurate temperature, and you need to write where you got the temperature from, because as a practitioner, that's important to me. Okay. If I had a 6-week infant and you did an axillary temp and it was 100.3, I'm going to ask you to get a rectal temp. You do not add a degree. Everybody's mom says that, right? Like, oh, if it's under, you add a degree. No, you do not do that. Okay. You just write down exactly what the temp was and how you took it. Do you understand? Yes. Okay. But if you did an axillary temp, we know that that's just a skin temp. Obviously rectal temps are better, but come to find out, babies don't like you, like, sticking stuff up their butt all the time. Right. And it can be damaging because their anus is like super tiny. So we only do a rectal temp one time when the baby is born. And that's just to make sure that there is an opening. Okay. Because imperforate anus is very common. Okay. And don't make fun of any conditions in PD. I've made fun of that condition for, I cannot tell you how long. And then I had a kid that had it. Okay. So do not make fun of any condition. I'm like, but it's wild. Like for Emmy, it looked like there was something there, but like it wasn't, there's no hole all the way through.
How do they know? Like, it just doesn't like advance.
Yeah. Yeah. And like some of them have like where it looks like there's something there, but when you go in, like, there's like, it's like goes to like a blind pouch. Okay. Like they fed her and everything before. Yeah. I'll tell you all the story really quick. So I had a perfectly healthy pregnancy. No problem. Had an absolutely beautiful delivery. It was the most gorgeous thing I've ever done in my entire life. I was so proud of myself because I had to find a doctor that did a VBAC. Right. So, it was amazing. And then they took her to the NICU just because I spiked a temp during, delivery, and they were like, oh, we have to feed her, yada, yada. And I was like, I really don't want you to, but they had to. So they fed her. And then I was like, I need my baby back. It had been like 3 hours and I knew like something was not right. So the doctor came in and she's like, I'm so sorry, but we fed her because she had hypoglycemia. And then one of the nurses was doing her assessment. So the doctor had come in, did the assessment, left the hospital, She goes to do her first assessment on the baby and she's like, I don't think she has a full opening. Like I can put something in, but I can't get it all the way through. Like it just stops. She's like, you need to come back right now because they fed her and she has no opening to poop out of. So the doctor like came back into the hospital. They had to stick a Ripogal tube down and like suck out all the feeding because it had nowhere to go. Yeah, she would have gotten like a really bad infection. And so they shut down NICU on day 2 and she got an ostomy and she had it for 6 months. So it's very, very common. Okay. And I'll tell you, let me tell you why now. Babies, whenever they're born, they develop cephalocaudally. So cepha means head and caudal means tail, because babies look like a little tadpole, right? So they develop from the head to the feet, and I'll explain that a little bit more in a minute. But when they're in utero, like they do develop a spine and stuff first, but everything kind of develops from the outside in. So they get like little arms and little buds, right? And everything ends up going right to the middle. So there's something called failure of midline fusion. So babies that have problems like right at the end, like of pregnancy or kind of towards the end, they don't fuse all the way midline. So if a baby has a problem with something midline, chances are there's other defects in the midline. So for her, since she had imperforate anus, they had to check all the other midline stuff. And she ended up she did not fuse midline in the front either. We didn't know that till way later. Because when she got her ostomy, she started peeing out of her belly button because there was an opening right through the middle, but we couldn't see it. Yeah, we couldn't see it. And then she had spina bifida because that's right down the back too. So when they have a failure of midline fusion, usually there's lots of defects right down the middle. So babies in utero kind of develop outside in. When they're born, and when they're born, it's cephalocaudal. Okay. And we're going to put all the handouts out in front of you in a minute so you can see what that progression looks like. Okay. But important thing to note, the only place that does rectal temps on all the babies, which should not, is a hospital that you're very familiar with. Yes. But they should not, that's been shown lots of times, like because you're taking temps on these babies every 4 hours, which means you're sticking something up their bottom 6 times a day. That's not, it's out of practice. You're supposed to do axillary temp. And then if the axillary temp you think is kind of on the high side, then you can do a follow-up rectal temp, but you shouldn't be doing that on all the babies. And that's really horrifying, to be honest. I mean, like, how would you feel if you're in the hospital already and then somebody's sticking something up your butt every 4 hours? It's very rude. All right. Very, very important to note, highlight, count respiratory rate and heart rate for 1 full minute because babies breathe weird. Okay. Did I show you all the prenatal and postnatal heart when we were doing like PDAs?
Yes.
Okay. So, when they take their first breath, everything changes, right? So their respiratory rate and their heart rate's weird. Like their heart rate's all over the place and their respiratory rate's weird. So babies may breathe like, okay. So if you do the 15 and then multiply times 4, like we usually do for adults, you're going to get a very weird respiratory rate and heart rate. Okay. And their heartbeat may go boom, 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 boom. Okay. So you have to do the whole minute and do not touch them. Do not piss them off until you've done both of those. Because once you start messing with them, they're going to start crying and you're going to get a 180 heart rate. And you're going to have to do something about it. Okay. So first thing we do is I walk in, the baby's sleeping and I'm just like watching their chest like this. And I'm saying, no, don't make eye contact. Don't look, just count. You understand? Okay. Apical pulse for infants is at the 4th intercostal space. That's just a stupid content question. That sounds like something ATI would say. Okay. So I explained to you that babies develop cephalocaudally. Yes, that means from head all the way down. So how that works, what I want you to do really quickly is I want you to lay out in front of you, okay, 2 months, 4 months, 6 months, 9 months, 12 months, all in a row. Okay, 2 months, 4 months, 6 months, 9 months, 12 months. 2, 4, 6, 9, and 12. Okay. So I want you to look at the babies that I picked. I picked these for a very specific reason. You see the 2-month-old, what's he doing?
Sleeping.
Laying down flat, right?
Yes.
Well, he looks very happy sleeping, but yes. All right. What's a 4-month-old doing?
Crawling.
Well, we're pushing up, right? They can only push up like to mid chest. What's a 6-month-old doing?
Sitting.
So now they develop 2 hips. What's a 9-month-old doing?
Standing.
So they've built 2 like knees. And that's in me. And then what is 12 months? Walking. So do you see how it goes? Like 2-month-olds have barely any head control. 4-month-olds can sit with supports. They can kind of push up a little bit. 6-month-olds can sit all the way without support. 9 months go down to like the knees and to sort of the feet. And then 12 months, they can walk. Does that make sense?
Yes.
Like down there.
Yes, it goes down the body. So if you can remember that, it'll make gross motor skills way easier for you. And each of these babies I picked for a reason. So you can picture that baby and you know exactly what that baby is doing. Got it?
Got it.
Okay. So that's why I wrote cephalocaudal, like head control at 2 months, sit supported 4 months, sit unsupported 6 months, crawl at 9 months, walk at 12 months. Y'all see that?
Yes.
All right. Important to note, these babies are in Erikson stage. Do you know what the Erikson stages even are?
I don't have them memorized, but I mean, if
Tell me what they are. What are they?
just the stages that like kids go through that kind of like develop, I don't know, their like psyche or like their mental health.
Okay, so it's something.
Yeah, like the trust versus mistrust, you know, if you pick up a baby when it's crying versus just kind of leaving it there, then.
All right, so they're
overall,
developmental things that
Yeah.
their brain has to go through to progress to the next one. Now, people can get stuck in one for the rest of their lives. Okay, so let's say there was a baby. Okay, so let's talk about this one first. Trust versus mistrust. What does trust versus mistrust mean?
you can, like trust other people versus not. Like again, like picking them up if they're crying, they'll trust.
All right,
you.
so the only
They'll
way
trust
babies have
you.
to communicate
is crying.
is crying, and they are trusting because they're into this random world that they don't know anything about. Like, this is so wild to me. All right, so I'm not sick, I'm just tired. Okay, anyhow, so when they are trusting that when they cry, their needs will be met. Does that mean to feed them every time they cry?
No.
That is very important to note. When they cry, it is not stick a bottle in their mouth or stick a boob in their mouth. Okay. They're crying to communicate some kind of need. But if you feed them every time they cry, then we're giving them the message that anytime you feel upset, you should just eat. You see what I mean? And then that sets them up for failure forever. But people can get stuck in this. All right. So how do we facilitate? Now, that's the most important part of knowing these stages is how do we, because I can tell a parent, your baby's Erikson stage is trust versus mistrust. Then what do they do with that?
Nothing.
Okay, so we have to tell them, how do you get them through this stage to the next stage? So how do I develop a trust with an infant?
Giving them attention.
Okay,
Not too much.
no, too much. You cannot spoil a baby.
Okay.
So everything you've ever learned is going to be totally turned on its head in here because
Okay.
they've lied to you about everything. Okay, you can't spoil a baby. That's their only way of communicating. They cannot visualize anything other than like what is going on themselves right now. Okay, so this whole like let them cry it out is horrifying. Okay, because all they're learning is I can cry and cry and cry and nobody comes. Right. And then they learn to mistrust their environment. Or if you have, this can happen too in a caregiver that's inconsistent. Okay. Sometimes when you cry, they come and they hold you and they, you know, and then sometimes they hit you or sometimes they don't come at all. And then you learn that people are very, you never know what to expect from people. And so you can't trust them anyway. Okay. But I will tell you, there's a rule. It's called the 75% rule. If you get it right with your kids, 75% of the time, no matter what we're doing here, the kid's going to be okay. Okay. So, cause there's no perfect parent. There's no way you can do everything right all the time, but 75% is, I can shoot for that. That's barely passing. Okay. But I passed. Okay. Anyhow, so how do we facilitate this? Tactile stimulation is how we get trust versus mistrust. Tactile stimulation means what?
Touching them.
Touching this baby. Okay. Babies will die without touch. You can feed them, you can do everything physiologically for them, but if they do not have physical touch, they will die. Okay. And this is so unethical, but they did a study on this. Okay. I might've told you. Yeah. Back in the day where you didn't have to be ethical. And they took these orphan kids, which is horrible. Yeah. In an orphanage. And they said, hey, let's meet all of their basic physiological needs. Okay. So we will change their diaper. We will feed them. We will do all those things, but you're not going to like hold them and feed them. You're just going to put a bottle in their mouth. Right. And they can move around and they can do all these things, but you don't touch them. And every infant in the study died. Isn't that horrifying? I know they're not allowed to do that anymore, but babies have to be touched. Okay. So then they decided, oh, we won't do it on babies because that's rude. We'll do it on monkeys. So they did a monkey study where they made a terry cloth monkey, like just made a monkey, like a mama monkey out of terry cloth. And then they made a, like a wire monkey. It didn't hurt when you sat on it, but like, it wasn't as comfortable, but it had the food. And they're like, people have, we know Maslow's, you have to eat, right? So what their hypothesis was, is that they're going to go to this monkey that has the food, right?
Yeah.
And they would for like the super shortest period of time that they could, like, you know, in the little bottle. And then they ran over to the terry cloth, right? Because they have to be touched, right? When they first created incubators, which was back in the day, and you know, they created them for a circus show. Did y'all know this? They used to put NICU babies, and the first guy that created the incubator, like, he would put these NICU babies in, and nobody had ever seen premature babies because they didn't ever live. Right. But once they had the incubators, they could, so they put them in like circus shows, and people would come and like as freaks, and people would come and like look at these little teeny tiny preemies in these incubators. They would buy the infants.
Stop it.
I cannot. Yeah. So that happened. Anyhow, all of that to say, babies have to be touched to survive. Okay. They do not need all the fanciest toys. They don't need the fanciest diapers or the best formula, whatever. They need to be touched. So now in the NICU, now that we know better, what do we do in the NICU? For all of our NICU babies, we do kangaroo care, right? And this could be dad, this could be mom, it doesn't matter, but they need a bare chest and we lay the infant there. And that works better than anything. Like babies that are having a hard time maintaining heart rate or maintaining respiratory rate, it's called kangaroo care, right? Little Joey, and you put them on mom's chest and immediately that heart rate comes down and the respiratory rate comes down. It is a beautiful thing. So babies have to be touched. Now, what happens when people get stuck in this? Let's say that there was an abuse situation or you had an inattentive mom that could not care for you at the time. They learn not ever to trust anyone because you don't know what's going to happen. You could cry and nobody will come, or you can cry and you may get hit, or you may get smothered or whatever. Like you cannot trust the environment around you and they will never get out of that because they can't get into the next phase. If you don't master one, you don't go to the next one. So what does an adult look like that's in that? They don't trust people. They become paranoid. They can't develop any relationships with other people because people cannot be trusted. I learned that from a very early age. Do you understand? Not me personally. I'm just telling you. Okay. Y'all were like, oh my God, you poor thing. Do you understand?
Yes.
Okay. So we've got to facilitate these or they cannot move to the next one.
Yes.
Okay. So these would be people that have like very short-term superficial relationships, like they want to physically be with somebody, but like they can't form any bond with anybody else. Does that make sense?
Yeah.
All right. Piaget stage. So what are Piaget stages? Oh, okay. Somebody tell you?
Yeah.
Okay, cool. So Piaget stages are more like how the baby is relating to their environment and how they're learning about, they're basically like an alien on this planet, right? It's like if we like took you and just put you on like a colony on Mars, and we're like, oh, surprise, there's a world here. And then you had to figure it all out. Okay. So in this phase, we're what we call sensory motor. Okay. Now sensory means touch and feel and stuff, right? And motor.
Movement.
Okay. So everything goes in there
No.
because that's how they learn about their environment is they taste it, right? And they bang it on their mouth and they they have to like do everything, right? So their senses is what helps them learn about the environment. And we would do the same thing if we were transported to another planet, right? If you had no idea how anything worked, is the ground hard? Is the ground soft? Am I going to fall through it? I don't know. I have to touch it and lick it. And right.
Mhm.
So they use all of their senses to learn about their environment and they can't learn it just one time. You have to test your hypothesis over and over and over again, which is why babies do the same freaking thing over and over again, right? We play peekaboo and what happens? Do it again, right? They first start eating and what do? They throw it onto the floor and then they're like, ha, ha, ha. And the mom's like, don't do that. And then what do? They throw it again. They're not trying to be defiant. They're trying to learn every time I throw this, does it fall to the ground? Every time I throw this, does my mom get kind of annoyed? Oh, okay. Now right? You got to test it a whole bunch of times before you figure out like, that's what's happening. Do you understand?
Yes.
Okay. So do we understand Erikson stages and Piaget stages?
Yes.
Okay. Fontanelles are a huge big deal in this class. You will have it in every module. Okay. What are fontanelles?
It's that
The
little,
skull.
there's two. It's like anterior and posterior.
Yeah, what is it?
The
It's like a
skull
little-
bones like
yeah.
closing, and then it's like a.
To allow the brain to grow and like,
Yeah.
All right. So they're holes in their skull.
Yeah.
Yes.
Bottom line. Okay. So they're, yeah, you're like, well, also, let me tell you some more about it. So there are holes in the skull to allow the brain to grow. Because the first year, the brain grows rapidly and a lot. And if their skull is already fused and their brain continued to grow, where would that brain go?
Spinal cord.
It will go down
Sit
the,
down.
what's it, that part in the back?
Oh,
Brainstem,
yeah.
which would
My bad.
basically kill the kid, right?
Yeah.
Okay, so since their brain is going to get really, really big, they have to have skulls that are very pliable and open to moving. So their skulls are very soft, which is why they're always like, support the head, So it's two holes, one hole in the front and one hole in the back. Okay, and then you have something called sutures. What are the sutures?
Where the bones.
Yeah.
Where the bones connect. Okay, so for adults, those are fused because our brain don't already growed. Okay. I'm a very smart when I talk this way. Babies are not, they're overriding. So their sutures are like this. Okay. So that the brain can grow. And eventually this will all line up. And then when their brain stops growing, it will fuse. Do we understand that?
Yes.
Okay. So they have two openings, one in the front, one in the back, and then they have these overriding sutures. You can actually palpate it on the outside of their head. They have these big old ridges. Okay. And then their skull has to be very pliable, meaning very plastic. I have to be able to like mold it because it's going to go through a badge. Okay. If it was hard, it would crush their skull when it went through a badge, right? If it was already fused. That's when babies come out, they're all cone headed because their skull is very, you can squish it around. So you gotta be real careful with their head.
Yeah, they look like peanuts when they come out.
Yeah.
Yeah. Because their skull's super pliable, right? And you can mold it kind of however you want. All right. But that's really important to know, because if you just leave your baby laying on their back all the time, what's going to happen to their skull? It's going to be totally flat in the back. Okay. And here's what happened with that. And this is very, very important. So these babies were dying of SIDS, right? Because we were putting everybody on their belly and they were just getting so comfortable that they forgot to breathe. That's what happens with SIDS. Okay. So babies are all like curled up like this. Okay. Or also they may get like their head kind of stuck like this. And because they haven't really developed head control and they can't move and they can't roll, then they just got stuck like that. Right. So they did this big campaign, which was back to sleep. It's called back to sleep, back to sleep. Okay. But what they forgot to tell the parents was back to sleep. You have to pick them up sometimes. Yeah. You can't just like leave them laying down all the time. And so all these babies got a completely flat back of the head. Now, what happens when the sutures fuse and we haven't fixed this? The back of their head will be flat forever. Okay. And then they have to grow like really long hair so it covers it because they look weird. Y'all seen a baby with a flat head? Yeah. It's bad because it's super mold and pliable. So if I lay them like this all the time, it will flatten out. That is called plagiocephaly. And it is very important to note plagiocephaly. I cover it somewhere, but I'm just letting you know. So when they did the back to sleep campaign, all these babies were getting plagiocephaly because they forgot to tell you like, oh, also pick up your infant. Okay. So back to sleep, just to sleep. And then you pick them up. Okay. And then there's also something that happens when babies' sutures fuse prematurely. That is called craniosynostosis. Okay. Cranio means stosis, narrowing, or yes, stiffening. So anyhow, if that fuses early, what happens to this baby?
The brain can't, it has nowhere to go.
It'll go somewhere.
Down.
Yeah, it's going to down to the brainstem. It's very, very bad. So you've got to check the sutures and you have to check the fontanelles with every visit that the baby comes in. And the reason I did 2 months, 4 months, 6 months, 9 months, 12 months, that's when they come in for their well visits. Okay. So that's why we study it like that. Okay.
Yes.
Okay. So the anterior fontanelle is a diamond shape. You see the diamond? Okay. And the posterior fontanelle is a triangle shape. It's teeny tiny right in the back. Okay. Okay. So the anterior fontanelle is the big one. That's what they call the soft spot, right? Okay. You can actually palpate it in these babies. So I'm going to pass her around to let you do it. So you can feel the front, and then the back is going to be like right here, and it's very small. Okay. So I'll practice on that. So fontanelle assessment can tell us a lot about hydration. Okay. So that hole, okay, is directly into the baby's brain. So please don't poke it. Okay. So a normal fontanelle assessment, you can poke this baby because she's not alive. Yeah. But in a regular baby, you probably ought not go poking in there. So the anterior fontanelle, or both of the fontanelles, should be soft and they should be flat, right? Soft and flat, soft and flat, soft and flat. That's normal. If the baby is dehydrated, what do you think you will see? Sunken. Sunken fontanelles. A sunken fontanelle means dehydration. Now, what do you think you'll see when the baby has increased ICP or hydrocephalus? What will that fontanelle do?
Rise.
Yes. Bulging and tense, meaning when you push it, it's like very firm. It should be soft and flat. Okay. You will see fontanelles all over the place, not just in this module. I'll fix her hair. She had a bow. Okay. All right. So the anterior fontanelle is a diamond shape. It should close. This is highly, highly, highly testable. It should close by 12 to 18 months. You need to assess the fontanelles at every single visit. The posterior fontanelle is very small. It is triangle shaped, and it should close by 6 to 8 weeks. We understand this.
Yes.
Okay. So what happens if the fontanelles close prematurely? They close earlier. Like I'm doing an assessment on this kid. The kid's 6 months old, and I noticed the anterior fontanelle is closed. What is that called?
Is that the plate?
No, plagiocephaly is the butt. Craniosynostosis. And now what do you think I'm going to have to do for this kid? They have to go to neurosurgery and break open the skull. Okay. All right. What do you do if the kid gets plagiocephaly? What do you think you will do if they get a flattening in the back? They don't have to do surgery. Yes, they put those little helmets on the kids to reshape their head. We want to catch it as early as possible because the older they are, the more that skull is going to actually like form and not move, right?
So a craniostenosis is whenever the fontanelles close prematurely.
Or the sutures are not overriding anymore. There's lots of different ways that can look, but it basically means like the skull has fused prematurely. Craniosynostosis. Okay. And then plagiocephaly we monitor for, and that we need to do education with the parents too. Right. And let them know to pick up their baby, and that the baby needs tummy time. Remember, it's back to sleep, not back during the day. Okay. So they need tummy time. Tummy time is one of the most vital things to do for babies. That is the only way they develop head control, their neck muscles, their shoulder muscles here, and all the way down to their back. That's how you're going to facilitate gross motor development, because they have to like push themselves up. That's how they learn how to get head control. Okay. All right. Do we understand fontanelles? You are going to plot every single visit on the growth chart. Now in your class, you will spend about 7 hours on the growth chart. You only need about 4 minutes. What is the growth chart? Don't know what a growth chart is?
Like where they're at on like growing, if they're gonna.
Yeah. So we do their height, weight, and head circumference until they, those 3 until they are 3. Because after 3, they should have already fused and all of that. Not for babies. Because baby, you know, they're going to be fat. And that's just mean to already label them overweight when they're going to be fat. We will do BMI on the older kids. Okay. But height, weight, and head circumference goes until age 3. Okay. And what we're looking at, we are not looking at any one point in time. We are looking at trends, because babies grow and then they don't, and then they grow and then they don't, because babies cannot do more than one thing at a time. They have to develop gross motor skills. They have to develop fine motor skills. They have to develop speech. They have to develop a lot of different things. And when they're working on one thing, the other ones are going to fall out. Okay. So what I'll see, like, and parents will freak out because like they went from like the 50th percentile to like the 25th percentile. They're like, oh my God. I'm like, but wait, has he had an improvement in speech, or has he all of a sudden started, oh my God, yes, he's talking like crazy, or he just started walking, he's walking all over the place. Well, you can't have them master everything at one time. So when they're mastering something else, the growth may slow. So what you usually see is more like this on the growth curve. You're not going to see a linear, kids don't grow linearly. There's no way to do that. So you never look at one point in time and make a decision. You have to look at the trend over time. Do you understand what I'm saying?
Yeah.
Okay.
Height, weight, and what was the other one?
Head circumference, which is called an FOC.
Oh, the fuck.
Yes. So it's frontal occipital circumference. Yeah, we'll talk more about that in a minute. So let me just quickly show you a growth curve. Okay. Y'all will spend like 7 hours on this in class, but I'm telling you, I can teach it to you in like 5 minutes. Okay. So just kind of tune out or something. All right. So this is what the growth curve is going to look like. And we're basically, there's lines that go like this. And we're just looking to see like how they compare. Now, keep in mind, all babies are going to develop at their own pace. Okay. Okay. So leave them alone. This is the 95th percentile, and every one of them is going to look a little bit different, but it's going to be something like this. Okay. 25th, you got 10, and then I need to do a 5. So it'll go by months. So you've got 2 months, 4 months, 6 months, 9 months, and 12 months, because that's when they come in for well visits. Okay. And then over here, you'll either have height, or you'll have weight, or you'll have head circumference. There's 3 different growth curves. Okay. And you'll plot every single one. And then over here, you'll have the measurement. Okay. Now, we're not looking at any one point in time. If you came to show me as a practitioner, like, oh, here's a baby's growth curve. What does that tell me? Nothing. Because what if the baby was up here on the 90th percentile before, and now they're down here on the 25th? That tells me something. They're majorly slowing down in growth, and I need to do something. What if the baby was like this? Then that was fine, right? So one point in time doesn't give me a lot. I have to look at the growth curve or the trend. Okay. That's why we plot them at every single visit. We kind of look and see. What you'll usually see is something like this, right? Because babies are going to develop sort of like this. Okay. Do you understand that?
Yes.
Now, if they are less than the 5th percentile, okay, if we're looking at something like this, okay, do y'all know what the percentages mean?
Can you explain it?
Yeah, because yes, I can. All right. So if the easiest way to explain it is, if I lined up 100 babies that were born on the exact same day as this baby that were the same sex as this baby, okay? And I lined them up all in a row from the shortest, because we're doing height, okay, from the shortest to the tallest, okay? And let's say the kid is on the 25th percentile, right? So they're number 25. That means they are taller than 25 of those 100 infants. That's easy.
Okay.
Yeah, that's all you need to know. Okay. And does the same thing for the weight. Okay. That's how I explain it to parents, because it makes a whole lot more sense. Otherwise, everybody wants their kid to be on the 50th percentile. That just means like, that's just an average, but who cares? If they're anywhere in here, we're doing fine. Every baby looks different. Okay. So if I aligned all these babies up from who is the least weight to who is the heaviest, okay, you can say that when they're younger, they would weigh more than 25 of those babies. But you do not have to be on the 50th percentile. The reason we have these percentages is because some babies fall below that and some babies fall above that, right? We're just looking for an average. Okay. I don't care where the baby falls as long as we're on the growth curve. But if they're consistently less than the 5th percentile, that's a concern.
Right.
Okay. What is that called when they're less than 5th? what disease do we label that?
Failure to
That's
thrive.
failure to thrive. Okay. There are 2 types of failure to thrive, and now they're kind of, I mean, they're going to be intermingled. So just know that that's kind of outdated, but just so you have an idea of what we're looking at. Failure to thrive, there's inorganic and then there's organic. So an organic failure to thrive means what?
That there's like a disease process or something like that.
Yes, they have liver disease, heart disease, something is causing them not to grow. Inorganic means
Neglect or something.
there's something psychosocial, and it could be breastfeeding issues too that mom doesn't know about. Okay. But most of the time it's kind of a mix of both. Okay. So that's why they don't like label it organic and inorganic or non-organic anymore. It's because it's going to be a mix of both, but know that it could be, I don't know. We have to admit them and then feed them and see how they do. Okay. And failure to thrive doesn't necessarily mean that the mom did something wrong, right? I mean, it could be a whole bunch of different things that we don't really know about. Okay.
Is CPS kind of like one of the things you have to keep like in your mind whenever you have someone that's below 5%?
You do need to keep it in your mind, but once you call CPS, you have ruined that family
Yeah,
for the
yeah,
rest of
but,
their
like,
life.
just something to-
Sure. That's why we admit them, because when we're getting reports from mom, she may say like, oh, the baby's eating 3 ounces every 3 hours. And and then we get them in the hospital, maybe it matches that. If it does match that, then it's probably something organic going on. If the baby just all of a sudden gains weight, then we're like, yeah. So we'll figure it out. All right. Do you understand how the growth chart works?
Yes.
I'm literally, that's it.
100%, yes.
That's it. Y'all will spend at least 4 hours on that.
Yeah, she wants us to print out some papers for tomorrow.
Yes.
10 papers. 10
But this is it. This is all you do. Okay. So from 0 to
Love that.
3, we do height, weight, head circumference. Okay. We're looking at the trends. And then over 3, you just do height and weight, because obviously their head should be pretty much the same size. Okay. And then after age 3, we only see them yearly for physical. So you'll do 3, 4, 5, 6, 7, 8, 9, 10, yada, yada. Okay. And all you're looking for, what I would look for on the growth chart is either under the 5th percent, that's concerning, or they have more than 2 standard deviations from the last visit. So let's say this kid was, at 4 months, we were on the 25th percentile. I see them back for their 6-month checkup. What am I doing? Height. And we are just below the 5th. I've gone one more than 2 lines. That's a concern. But you need to be careful in PD, especially on exams. If they ask you, how would you interpret this on an exam? You're not going to tell the mom there's something wrong with their kid. You will never say that, because it's none of your business and you'll freak her out, right? You'll just say like, oh, we need to ask you some more questions about the growth curve, or let me look in the past. You're going to say something very generic. You are not going to say, this is very concerning and I need to do so. No, you're going to be like, oh, I see that we've changed on the growth chart from last time. Let me ask you some questions. How is he feeding? Yada, yada. You can never diagnose with anything.
Yeah.
Okay. Even if it said the baby has been under the 5th percentile for 2 checkups, what are you going to do? Diagnose failure to thrive? You
No.
can't. You're going to say, oh, okay. I'm noticing on the growth curve that we're under the 5th percentile. Can you show me how you feed the baby? It's going to be something very generic. You never say there's anything wrong with their baby.
Yes.
Okay. All right. Okay. Important to note is the rule of halves. Okay. So the rule of halves, I made this up just so you know. So don't go into class and be like, can you explain the rule of halves? No. Okay. So the rule of halves helps you to understand how this baby is going to grow. So until they're 6 months of age, their weight is going to increase 1/2 to 1 ounce a day. Height, 1 inch a month. FOC, which is head circumference, 1.5 centimeters. So it goes half, 1, 1.5. You understand that?
Yes.
Second